Hi, everyone, and welcome to our Health Talk. My name is Alina, and my pronouns are she and her. On behalf of the Patient Education and Engagement Program here at the University Health Network, thank you for watching this session on outcomes after a critical illness. At UHN, we strive to provide safe and inclusive care, and that begins by honoring Indigenous peoples. Indigenous peoples are the original inhabitants of this land and for thousands of years have cared for this land. Although we are presenting this Health Talk in the digital world today, we want to acknowledge, remind ourselves, and encourage you to do the same wherever you are currently located, that we are still on the traditional territory of many nations, including the Huron-Wendat, the Haudenosaunee, and the Mississaugas of the Credit River. This territory is governed by the Dish with One Spoon Wampum Belt Treaty, an agreement to share, care for, and protect the resources around the Great Lakes in peace and respect. Today, this territory is still the home to many Indigenous peoples from across Turtle Island. We are grateful to have the opportunity to work, learn, and play on this territory. And as we talk today about mental health challenges and access to care, I'm also keeping in mind how Indigenous peoples face further challenges in accessing mental health services. And I'm looking forward to hearing from our speakers today to learn how we may be able to overcome some of these challenges. And thanks to those who have submitted questions, we will answer questions towards the end of this session. A reminder that you can start submitting questions at the beginning of each month on slido.com using the code UHN Health Talk. And I'd like to take a moment now to introduce our speakers. Christine Patton is part of our UHN Patient Partner Program and part of the Brain Quality of Care Committee. She loves to walk at least 6,000 steps every day, and when it's really cold outside, she enjoys baking, including attempting the perfect loaf of baguette. And Christine will be sharing her story with us shortly. Dr. Harridge is a professor in the Department of Medicine, a senior scientist in the Toronto General Hospital Research Institute, and research director for the University of Toronto Interdepartmental Division of Critical Care Medicine. She is a Tier 1 Canada Research Chair in Critical Illness Outcomes and the Recovery Continuum, and a recognized international content expert on patient and caregiver outcomes after critical illness. And finally, Dr. Adrienne Tan is a associate professor of psychiatry at the University of Toronto's Temetry Faculty of Medicine and a consultation liaison psychiatrist at UHN. She leads the Division of Medical Psychiatry at the UHN Center for Mental Health, which provides psychiatric care to individuals with complex medical or surgical conditions. So we have a really knowledgeable group of speakers today who will go through with us what a critical illness is, the social conditions of that impact someone's health journey and health outcomes, and also we'll talk about common health challenges for patients, caregivers, and children after a critical illness. So with that, I will hand it over to Christine to start us off.
Thank you so much. Hello, everyone. My name is Christine Patton, and I am honored to share my story about my ICU experience and the impact of mental health following that. Thank you for the introduction from Alina, but wanted to let you know that I've lived and worked in Toronto all my life with my husband and my 2 kids. Previously, I had worked in business development and marketing in a very long time. We won't talk about my age, but now I volunteer at the Toronto Rehabilitation Institute, talking to patients and their families with acquired brain injuries. And I'm also a board member of the Aphasia Institute, a not-for-profit for those with communication disorders like me. While this is my purpose now, I didn't expect to have the shift from director at a global law firm into this in a blink of an eye. Could you please try? Thank you. In 2016, my husband and I had our trip of a lifetime in Italy for our 25th anniversary. And about a month later, things went horribly awry. While I have always had migraines, this one was a doozy. Still, I went to work that morning and started noticing that something was weird. I actually called my husband that morning and said, there's something not right. And he offered to drive me to my own doctor. That's when things started getting a bit fuzzy for me and for my husband, as he realized my speaking wasn't making sense. The last thing I remember was being in the local hospital, and they asked what was my name, and I said, my name is Tomato. Welcome to the world of a massive brain bleed, evidently. I was transferred to Toronto Western, in which the doctors told my husband, it's worse than we think. If she survives, she could have massive deficits. Good news, I survived. Yay for me. I was two weeks into the ICU, a week in the hospital, and then directly into Toronto rehab. But I started learning how many challenges I would now have. Post ICU, but still in the hospital, I couldn't hear clearly. Someone had to feed me, as my dominant right hand was totally busted. I was in a wheelchair. My memory was shot. I couldn't think the right words correctly or even know my husband's name. I'm a wildly independent person, but it is hard to imagine that the big goal was getting into the bathroom with assistance. As you can imagine, it is like back to being in their kindergarten all over again, and I was not happy. My first aha was when the medical doctor said that there will be lots of appointments after your survival and tests, but eventually that will dissipate over time. And that was it, nothing else. I don't recall they shared the possible impacts of anxiety, depression, or mood changes, which impacted to me. That said, I was so focused on my medical aspect first. Can I finally brush my teeth? Could I cut my dinner? Could I move from the bed to standing up? And then the communication was the second part for me. And it wasn't, I certainly was not ready to talk about the emotional side. That's not only about the patient. I have learned that the trauma experience was far worse for my family. Unfortunately, I didn't see the gown or the initial indication of surviving before surgery, but my husband, my son, and my mother did. In the ICU, I didn't see all the staff team checking me every 15 minutes, seeing bandages, tubes, drips, and all the medical machines that go bing, a la Monty Python. But my family watched my side, waiting to see if I improved. While I was unconscious, my family were devastated on a wide range of sad to stoic and mad and everything in between. So I am 7.5 years in. I walk, I talk every day, but I cannot drive. I continue to improve my communication with weekly homework. I still have no memory of my 2 weeks in the ICU, and I continue to ask my husband regularly, just because I want to know. And I am managing my anxiety issue and sharing my updates with my family so that we could progress together. So looking forward, my body is upset. The body is upset for such a trauma experience. So everything takes a little bit longer to heal. It's okay to slow down, rest more, and it's okay to recuperate as much as you need. Number two, the progress changes from 1 week, 1 month, 6 months, 12 months, 18 months, and beyond. That's the progress that you work on. And make sure you share your successes for your family and those around those areas you want to continue to build so that everyone is on the same page. And finally, my trauma was enormous, but double the trauma for my family members. And like us, no one is equipped to understand and address this situation. In retrospect, I should have reached out for help just for myself, for my husband, and for my children, individually and as a group. So I strongly encourage all patients and their families to gain support, whether it's nurses, social workers, spiritual guides, anything that you can to help you and your family move forward. Thank you so much.
Thank you so much, Christine. Really appreciate you sharing your story, and there's so much we could learn from you. So thank you. I'll pass it off now to Margaret to take us through critical illness.
Thanks very much, Shalina, for the opportunity to speak today. And Christine, thank you very much for having the courage to share very personal information with all of us and some of the challenges that you and your family have been through. And I'm going to talk a little bit about how many of the things that you experienced are very common in many patients and family members after critical illness. So again, sincere thanks for coming today. Have the next slide, please. So many people watching this video may not exactly appreciate what a critical illness is. Critical illness is not experienced by everyone or in every family, so not everyone is familiar with it. I would say since COVID, people have become much more familiar, tragically, with critical illness because there have been so many media images within the ICU and an increase in lay knowledge about ventilators or breathing machines and what the various monitors and equipment actually look like, because there's been so much footage now in the media. I think that's helpful, that people have some images of it. And I'm just going to define this simply as critical illness being any life-threatening condition. And in Christine's case, this was a brain bleed, but in many other patients, this could be a severe infection, a buildup of fluid in the lungs from an infection. This was COVID pneumonia that brought so many people to the ICUs in the past few years. And it's a place where you need a very high level of support of vital organ systems. I'll talk about that in a minute, but including both mechanical support from machines and different medications. And this treatment can occur in different intensive care units in the hospital, because the different intensive care units specialize in terms of specific medical illnesses. I personally work in the medical surgical ICU here at the Toronto General Hospital, and we look after very, very sick people who are referred to us across the province. We look after people who have very severe infection. complications of transplantation. Very, very sick folks. There are other ICUs, the cardiovascular ICU that people after heart surgery will go to, the coronary intensive care unit, people with serious life-threatening heart problems will go to, pediatric intensive care unit for children under the age of 18, neonatal ICUs for children who are born prematurely. And Christine was in a mixed medical surgical neuro ICU at the Toronto Western Hospital, which is our sister ICU at the Western here at UHN, where they're looking after many different types of critical illnesses. Next slide, please. So just some examples of mechanical support and medications. As I indicated, the ventilators that many of you have seen on TV now in the context of COVID and the news stories. These are breathing machines. These are machines that are taking over the work of the lungs. They're putting air into the lungs under pressure, and they're delivering a much higher oxygen level to the lungs than what we're breathing on room air, which is 21% oxygen. So this is really helping to overcome infections in the lungs, but it also supports breathing in patients whose brains have been injured and whose brains cannot initiate breath normally. So there are many indications for that. Medications that raise the blood pressure, they're called pressors. And these medications are run intravenously through large veins. They're run continuously. There are a whole host of different medications that do this. They have slightly different functions, but the overarching function is to artificially elevate the blood pressure during a critical illness to keep the blood pressure in a safe range for the patient while the patient is able to recover through the illness. Heart-lung machines have been in the press more lately. These machines were talked about in COVID as well in the media. These machines are the highest form of mechanical support or machine support that patients can be on. We use ECMO here in the Toronto General ICU. We're one of the largest centers for ECMO in Canada. And this takes over the entire function of the lungs or the entire function of the heart and lungs in combination. There are different types of ECMO. And these machines are used for very extremely critically ill patients where there are large intravenous lines that are really the size of garden hoses that are removing all of the blood from the body, running it through a machine to add oxygen, to remove carbon dioxide, and then place that blood back into the patient's body. So it's a way for machines to completely sustain a patient whose lungs do not work at all. They exceed the limits of a ventilator, a breathing machine, and or they need support for their heart as well, in addition to their lungs. Next slide, please. So there are many conditions that can follow an intensive care unit stay in an episode of critical illness. And many people over decades have published on all of the different medical problems, mental health problems that patients can sustain after a critical illness, and also, as Christine indicated, family caregivers, children, parents. There have been many outcome studies published over the years in different areas of critical illness. And in the last 10 years, there's been the development of a term, the post-intensive care syndrome, to try to find a simplified, all-encompassing term that tries to address many of the common challenges that patients and families have after a critical illness. So patients after critical illness may have new physical or mental health or cognitive challenges. Cognitive meaning how your brain works. They may also have worsening of pre-existing physical or brain thinking or cognitive or mental health challenges. It isn't ageist to say this, it's just biology, that the older you become, the more vulnerable you are to disability, and the harder it is for your body to recover. And in the critical illness literature, the older you are, and 65 is not old, but it is when you become very, very seriously ill. If you had prior problems with frailty, and frailty isn't just weakness, frailty is just a global decline in your ability to function, whether you need a lot of assistance with daily activities, whether you've had previous health problems before you've come to the ICU. All of these things make you more vulnerable and make it harder for you to get better after ICU and more likely to have some of these disabilities that are described in the post-intensive care syndrome. Now, the longer you stay in the ICU, after 2 weeks, with every additional week, patients will tend to have more physical disability. They will have more challenges with muscle function and muscle strength, and may need to learn how to walk again. So it's very expected for people who've been in the ICU, even 1 week, the majority of patients, regardless of how old they are, even teenagers who've been very, very sick and have been in bed and immobilized for a week or longer, the majority of those patients will need to learn how to walk again. Younger, fitter, less medically complicated patients will reacquire this faster, but there's disability really for everyone on average. Next slide, please. And this isn't intended to be a bad news story. It's intended to be a real story so that people are aware and that we're speaking honestly about some of the challenges that patients and families and caregivers have after critical illness. And this is an important barrier in critical illness and outcomes because it's not necessarily information that's commonly discussed, commonly in the lay press, and that people tend to know a lot about. For example, people tend to know a lot in the lay public about heart disease or cancer or some other medical conditions that tend to get a little bit more media attention, or conditions that are a little bit more understandable or accessible. Critical illness deserves that kind of dialogue and discussion, and I'm grateful to the Health Talk folks for highlighting this, because it is an area that people know honestly very little about, even medical colleagues who don't work in critical care. And in addition to the wide range of physical disabilities that people may have, there are a lot of challenges with transitions of care. It's always hard to move from the ICU to the ward, from the ward to rehab, from rehab to home, and from home to work, back to work. Excuse me. And these transitions can take weeks or months or years in some situations, depending on how sick someone's been. And the recovery process, as Christine so graciously has shared with us today, can be years and ongoing. And it's important for everyone to understand that and to be aware of those things and to understand that help is available. And I hope increasingly there will be formalized pathways for patients and families after critical illness to address this broad range of need, and to also help to improve quality of life, and to help folks return to their original work if they wish, or are able to, modified work, or whatever kind of work or meaningful activity patients and families have after having been through this traumatic life event. Next slide, please. So this is an image from a review article that a French colleague, Elie Azoulay, and I recently wrote for the New England Journal of Medicine. And this may strike some of you as a disturbing image. And I want to just say a couple of things about that. As a senior critical care physician here at the UHN and in the Toronto General ICU, I look at this picture every day. This is a picture that's very real, and it is disturbing, but it's truthful. And truth matters. This is what our patients and their families are going through every day. And this is what Christine indicated in her talk. The patients are often in bed. They have a lot of tubes and lines in them. They have a breathing tube placed through their mouth, and it goes into their windpipe or their trachea. The patients are often so sick that they're on medications, not just to sedate the medications, but to treat pain, because it's very painful for the patients to be immobilized in bed. And you see at the bedside a whole host of machines here. They're breathing machines. There are intravenous machines running these pressor medications to artificially elevate the blood pressure. There's an ECMO machine here, the heart-lung machine. This patient's on the heart-lung machine. And there's a dialysis machine that takes over the work of the kidneys. This is as sick as you can become in the ICU. And since I work in the sickest ICU in Canada, that's here at the Toronto General, we have patients like this. Almost all of our patients look like this. And we showed a picture here of the family caregiver, children at different stages of development, and a mother, because the critical illness is affecting the entire family and is creating intergenerational trauma. Everyone is going through this, and it's a very difficult scene to be involved in. It's a very difficult bedside vigil. And that's the reason to show this image and to help everyone who doesn't work in an ICU or who hasn't experienced this firsthand to understand that this is a very, very difficult life experience that affects everyone quite profoundly, but differently. Next slide, please. And to try to explain that while these events begin in the ICU, they continue into the home. And this is a picture of the home of this patient and her caregiver and the children and her mom. And you can see that this was a young patient, but she's still in the process of needing help with mobility. And her husband's here helping her. And the children have been through a very difficult time, and they're withdrawn. They're hiding. The youngest is hiding. And the mother is exhausted. These aren't ideas from me. This is what the post-ICU literature teaches us. And we need to really be aware of this and to help offer assistance to the patient, but also to all the family members, because there can be a lot of caregiver and financial stress, mental health issues that Dr. Tan will address in a moment. And when there is loss in this kind of high stress, high anxiety, traumatic environment, patients and the families may suffer from prolonged grief, complicated grief, and need help with that. And to also explain that patients and families may have time away from work, away from school, and that people are supported adequately through some of those challenging transitions. Next slide, please. And this is just a table here outlining again the care transitions from ICU to home. I've talked about most of these things, but just to explain that these transitions can be weeks, months, years, and that it's different for different patients depending on who they were when they came to the ICU and what sort of challenges patients had to face during the ICU. And some of the additional harms, unfortunately, we add in the ICU in an attempt to save someone's life. And that's some of the drugs we expose patients to, the immobility in bed, and many of the care interventions that we need to really get someone through a significant medical crisis. Next slide, please. And this is a picture of a patient. You see this patient inspired the illustration that I showed you. This is someone I looked after who was in one of our follow-up studies, who encouraged us to use pictures that her husband took to educate, to help people to understand what the critical illness looks like, even though the pictures are scary. And to show that 2 years later, she was able to recover, but that the pathway was difficult. The pathway involved enormous amounts of rehabilitation that were difficult. Challenges with mental health, challenges within the family, the young children, her husband. And just to illustrate a real life example and to emphasize that the patient herself and her husband here really wanted us to include this in educational materials that our own group often uses to give lay talks about critical illness and outcomes. Next slide, please. So there are a wide range of disabilities. I'll quickly go through these here, but there are many, many things that are challenging. New or worsening frailty. This is really a global decline, but it can be manifesting as weakness, immobility, really an ongoing failure to thrive, weakness and injury to nerves and muscles, from the breathing tube injuries to the mouth, teeth, and gums, and an inability to give good oral hygiene. This is a big issue in the ICU. Often patients acquire new scars, so they have changes in body image, and that it requires adjustment after the ICU as well. Pressure injuries from being in bed for a long time and the wounds that result from that. Often they can take weeks to months or even longer to heal. Sometimes patients will describe taste, hearing, or vision changes in the ICU related to some of the drugs that we've used. New kidney problems. So we showed a picture of a dialysis machine in that illustration from the New England Journal Review. That can happen not uncommonly. When you're immobilized, your joints get frozen because we're not made to have immobile elbows, knees, shoulders. And so sometimes that can be very debilitating in the longer term. Next slide, please. And muscle weakness, as I already mentioned, is the most common and persistent challenge that patients have on average. And there may be other challenges, and Christine described some of the challenges that she had with her brain injury resulting from the bleeding. But in general, just being in the ICU results in a lot of weakness, and this can persist for a long period of time. And some of the risk factors for disability I've already discussed. But I think we all really wanted to normalize the fact that disability is common, and it can be very persistent, and to frame expectations so that people can get help, the help that they need. And that may go on for months or years. And that can be in terms of physical, mental health, cognitive or brain thinking challenges. Next slide, please. There are many barriers after discharge. We've already talked about a few, talked about patient characteristics, the environment. Unfortunately in Canada, but I and many of my colleagues in Canada are really on a mission to formalize and standardize post-ICU clinics and follow-up. To really make that a robust standard model after ICU. It's hard if you live in a small town to get to a lot of the specialized care that people may need, and many people are working hard to try to create pathways for that. COVID helped a lot in terms of increasing virtual care. Not perfect, but a way to get around some of those barriers, other ways for patients to be transported. Thankfully, in Canada, people don't leave ICU with millions of dollars of debt the way they do in other health care systems. That's true. But there are really is a lack of extended health insurance. Not all medications will be covered, and a lot of patients need additional physiotherapy, occupational therapy, assistive devices that are really not covered. And that becomes a financial burden for many patients and families, especially when people are having challenges returning to their prior work. Next slide, please. So really messaging, and not in any way a negative comment, it's a real comment, just an educational comment, that survival does not necessarily mean a complete recovery. But we have a lot of work to do to really make sure that survival from critical illness is highlighted, that there's a public agenda, a policy agenda about this. COVID highlighted this for us, for those of us who did critical care and worked through COVID, which was its own breathtaking professional experience, but worse for our patients and families, of course. We have a lot of work to do in terms of taking good care of people and their families on the back end of a critical illness. Next slide, please. I think I'm done. Thank you very much.
Thank you, Dr. Herridge. I'll hand it over next to Dr. Tan to talk about mental health. Over to you, Dr. Tan.
Great. Thanks so much, Alina. I wanted to begin by thanking you for stewarding this process and, of course, UHN Health Talks. But a particular thank you to Dr. Herridge for all these number of years of collaboration clinically and in a scholarly way in the Recover program. We've learned a lot from her in the Center for Mental Health. And also, been very glad to be able to contribute meaningfully. And of course, a thank you to Christine for sharing her story and a bit about her family's story, which echoes so many of the families and of the patients who I see post-critical illness and, some of the experiences that they've had. And we're going to cover, some of the mental health sequelae or consequences of critical illness and to normalize that mental health struggles are a part of the recovery process. Next slide, please. So we're going to begin with a little bit about what mental health is, and defining that, to talk about distress as a more sort of global or encompassing, concept, that distress is normal, right? And it can range, from normal feelings of anxiety and sadness and depression, all the way to more serious conditions that require, professional help. And then we'll more specifically talk about mental health outcomes after critical illness. And of course, Dr. Herridge already spoke about this, about post-intensive care syndrome. We'll focus on the mental health components of that. Next slide, please. So mental health, most broadly, encompasses how a person's lifestyle choices affect their feelings and sense of well-being. It is about how we think, feel, and act. And, as we may all know from the World Health Organization, there is no health without mental health. And this is, meant to highlight, the integral part that mental health plays in all of our lives and to destigmatize mental health conditions. Next slide, please. So distress, what is it? It's a normal part of life. It's an unpleasant emotional and psychological experience. It can involve normal feelings of vulnerability, sadness, depression, anxiety, even more serious anxiety, panic, social isolation and spiritual crisis. And it ranges, from normal feelings after, a major stressor, loss, or traumatic event to more serious and persistent symptoms that may require, as I noted before, professional intervention. Distress can occur in both patients and caregivers. These can include most commonly family caregivers, but there are many individuals too who have other caregivers in their lives who play integral roles in their recovery from critical illness and in the acute phases of that. I think the other thing I wanted to note as a point of education to the public, and this is something we offer at UHN, but is available across many different hospitals, specific psychiatric services to medical and surgical units and to the intensive care units or critical care units across hospitals. But that's what we do in consultation liaison psychiatry. That we provide that care in inpatient and in outpatient settings, and we see, the whole range of distress in patients, post-critical illness, but also with a variety of other medical and surgical conditions. Next slide, please. So in terms of mental health outcomes or after intensive care admission and survival, As I mentioned before, there can be depression, which is very common, anxiety, and of course, post-traumatic stress disorder. Many patients in the intensive care unit experience very frightening experiences that they may not understand. A lot of the time, patients are what we call delirious. So they have an acute confusional state where they may be unaware of where they are or what's happening to them. Patients can also have very disturbing experiences involving loss of touch with reality, including visual and auditory hallucinations and, frightening delusions. Some patients have told me that they felt that they were being imprisoned, being tied down, or being experimented on. And some of these memories can be very, very disturbing for patients and can interfere with their care moving forward, where patients have, severe anxiety or avoidance of medical interventions or the hospital, which, is very challenging when you need to go back to the hospital for care after surviving critical illness. There can also be profound changes in your memory, so in your so-called cognitive functioning. So there can be memory loss. There can be also, evolution of more serious memory issues, including dementing disorders or dementia. And this most often occurs in individuals who have, pre-existing memory impairment that is accelerated by the process of critical illness and of the delirium that they may have suffered from in the ICU. And also ongoing communication challenges, and that can depend on the nature and extent of the medical issues that you suffered or patient suffered from in the ICU. So, of course, Christine spoke about aphasia and difficulty with language, and that had to do with the specific, brain regions that were affected by the medical condition that she had. Of course, Dr. Harridge referred to ongoing physical impairment after critical illness, in particular weakness and mobility challenges. And of course, we are not, psychological, and emotional, and physical selves separately. They do feed into each other. And I think the point is that it's hard to feel yourself, hard to feel good about yourself, and your life when you have persistent disability, and how to live with, tolerate, and still feel hopeful about the future, when you have had some loss of function. And this can really drive feelings of depression and anxiety and other forms of distress post-critical illness. There can also be a host of psychosocial challenges because, of course, people are taken out of their regular lives. There can be financial struggles, both because, family caregivers can no longer work because they have caregiving responsibilities or have, lost their jobs in the course of their caregiving responsibilities, unfortunately. And of course, for the individual who had the critical illness, they may no longer be able to work for a period of time and, may or may not be able to return to their previous position. And of course, the very significant impacts to relationships. And these are things, that often evolve, months to years after, recovery from a critical illness. The experience we've had in medical psychiatry with patients with critical illness, but also other serious illnesses, is that's not until you feel safe with some sense of stability in your medical condition and your physical well-being that you really start to take stock of all the other things in your life, including, the burden and the responsibility on your caregivers, what's happened to your life financially, the impacts that it may have on those, who have young families, or even, elderly parents who have come to, take over some caregiving roles. And grief involves, of course, the feeling of loss. And this is, we talk a lot about loss, here, and also things that we can gain and hope, of course. This isn't just, sad stories. There are stories of, suffering and of survival that are highly inspirational. And as Dr. Harridge noted, we wanted to talk about things that are real. And there are real losses. And when we begin, to be able to face them, is when we can begin to disentangle some of the distress that people feel. Because often it's, what is unarticulated, what's not said, the elephant in the room that continues to drive distress, and doesn't allow for the opportunity for help to be made available. Next slide, please. So in terms of post-intensive care syndrome and life after critical illness, we wanted you to know, all patients and families to know, that when patients leave a hospital, the vast majority of them at discharge have some post-intensive care symptoms. As Dr. Harridge noted, survival isn't the same as recovery. It takes time, weeks, months, years, depending on what occurred in the ICU and somebody's medical status before the ICU, and of course their age. And about half of patients continue to have symptoms after, a year after discharge. And this is through a host of complex factors, Of course, individuals with pre-existing mental health conditions are at higher risk of, post-intensive care, as symptoms of depression and anxiety, but they can also happen on their own as a result of the significant physical, emotional, psychological, and other stressors in your life that occur with critical illness. But we really wanted to emphasize that this is an integral part of recovery and that there is help available. Next slide. So there are a variety of mental health treatments available, depending on the nature and extent of the symptoms that patients are experiencing. The simplest and easiest, of course, are lifestyle modifications, although sometimes easier said than done. To think about your substance use, in particular alcohol, which can help relax folks and decrease anxiety in the short term, but longer term can be a depressant and disturb sleep. And so, to really think about substance use, sleep hygiene, maintaining your biological rhythms, really caring for yourself in that way. Regular exercise can also be helpful for your mood and, of course, for your physical recovery and other self-care behaviors. The other thing I wanted to mention here that's really important is a sense of compassion for yourself, that it takes time. And that oftentimes, because there was a period when patients were sedated in the ICU, they don't remember the part when they were the sickest, and began to acquire a lot of the disability. And then when they wake up, they're a different self. And to allow yourself some space to gradually regain functions that you may have taken for granted. And as Christine noted, to be patient. It takes time, and with persistence and support, recovery does occur. Psychotherapy or talk therapy, there are a whole host of different kinds of talk therapy, from more open-ended ones to more manualized, time-limited ones, depending on the nature of your symptoms. Different types of talk therapy may be helpful for you. Sometimes, just the ability to put together all of the different pieces of what happened is in and of itself therapeutic. To understand the gap between, when you last remembered, either coming into the hospital or feeling unwell, to when you woke up and saw your relieved family members at your bedside, and to put all of those different pieces together and to try to think about that in the context of who you felt you were before, who you've become since then, and who you'd like to be in the future. That it is often about sort of mourning the self that you were before, and then thinking about the possibilities of who you can be moving forward, that allows people to really flourish after critical illness. There are also, in more serious conditions, medication therapy that can be offered, including antidepressants, anti-anxiety medications, and mood stabilizers, depending on the nature of your symptoms. Many patients also suffer from insomnia, especially if there's pain. And there are various, of course, lifestyle factors to consider there, but there can also be, relief sought from a variety of sleeping medications, especially in the short term. Next slide, please. So when to get help? I want to emphasize that you should get help at any point in time, but especially if you find that the symptoms you're having, the stress that you're experiencing is negatively impacting on your relationships, your work, or your sense of yourself, your own self-esteem. If the symptoms are causing significant subjective distress, they're disturbing to you. Sometimes we describe things to other people and they may or may not know how serious it feels inside for you. But if it's something that's really bothering you and it doesn't feel right, you should get help. If you're feeling sad most days, if you find that the things that used to bring you pleasure don't bring you pleasure anymore, or anxiety that kind of, freezes you, that you can't move forward in your life, or that you can't do things that are helpful for you, in terms of, some of the lifestyle changes we talked about, or engaging in medical care after critical illness. Next slide, please. I think I'm going to turn it back over to Alina. Thank you.
Thanks, Dr. Tan. And yes, we will share some more resources on where to go if you need support. If you or a family member is experiencing a mental health crisis, there is 988, a suicide crisis helpline. You can go to your nearest emergency department or call 911. Some other helpful links that we will include in the description box below are the Canadian Recovery Program at UHN, the Society of Critical Care Medicine Patient and Family Resources, the Canadian Mental Health Association, different resources to find a family doctor or a specialist doctor in your area. And last but not least, you're always welcome to contact the Patient and Family Learning Centers at UHN. They offer reliable and up-to-date information to patients, families, healthcare providers, and members of the general public. All of their services are free to use and they're available in multiple languages. So you can call, you can email, or you can visit them between Monday to Friday. So with that brings us to the question and answer component of our health talk. For those who have submitted questions, we have removed your name, so we only have the question there. Okay, so our first question. While staying in the ICU during and after the intubation, I was treated with a lot of medications, including antibiotics, sedatives, and so on. At the discharge, I felt being in the dark and not provided with any kind of info on medications and or type of treatment during my stay at the ICU. So the question this person has is why, and is this the usual procedure? So Dr. Harridge, maybe you could give us a little bit of a perspective on this.
Sure, thanks, Alina. I guess I would first start by saying that unfortunately, this is very common. Because in Canada, like almost every other country in the world, there is no standardized follow-up for patients and families after critical illness. And we're certainly trying to change that and address that, but that's the way things are currently. I think in terms of where things are at right now, there's some resources that we shared here, ways that you can get in touch with people and access help. And information. One additional suggestion is, at least for those patients at UHN, the UHN has created this very transparent interface such that patients can really, through the UHN patient portal, see all of their information. Now, a lot of this information will really be in some may be in an accessible form. Most will be in an inaccessible form. People are writing notes that may contain a lot of medical jargon or short forms, etc. But I think having that information, access to it, hopefully can bring some insight, some transparency to what happened. And for those things that need a little bit more explanation, that information can be taken to your primary care physician, or patients and families can access, other caregivers in their world, other specialists they may be followed by. Those people will also be helpful in terms of interpreting those data, as well as some of the resources that have been included here. And I don't know if Christine had any additional comments that she wanted to add to this question.
Thank you so much. This is a compelling conversation about someone feeling that they're out of the loop. And I think, so as a patient, I was just focused on getting, can I stand up? Can I, move forward physically? I'm not able to understand sort of the broader ramifications of that. Mm-hmm. So I think this knowing that there is a number of resources available that wasn't there 7.5 years ago, but certainly more opportunities to just ask, whether it's a nurse, a caregiver, a PSW, anyone who can start giving the direction in the right spot. That would be the most helpful for them.
Thank you both. It's really helpful to get both of your perspectives on this. Our next question is about support. So How can you ask for help, and where and when do you start looking for support? So Dr. Tan, maybe we can bring you in on your perspective on this.
Great, thanks so much, Alina. So we understood this question as asking for mental health supports. I think it depends on sort of the phase of where you are in terms of your critical illness. Initially, when patients are in the hospital and are very sick, if they need any mental health supports, that occurs through the treating physicians on the team, requesting, the kinds of mental health supports that are available in the hospital. Most hospitals do have psychiatric services available, and depending on what the patient's experiencing, they may ask, a variety of individuals to come in. Many hospitals, like at UHN, we also have spiritual care and social workers to assist. Sometimes, help in the hospital means help for the family member who is supporting the patient who's quite unwell and maybe sedated and sort of immobilized at that time. And in that case, spiritual care and social work can also be of assistance. Later, when you're out of the hospital or like in rehab, many rehabs also have mental health services available. So really, the message is to ask for help anytime, and that can come from the patient, from a family member, or from a healthcare provider. And of course, post rehab, there are other resources as well available in the community, like community mental health resources, but also more formal mental health resources through mental health or psychiatry programs at local hospitals or agencies. And, you can ask for help through your primary care provider or through your specialist physicians as well, who can make, referrals as needed. And you should, start looking for help whenever you feel like you need it. We spoke earlier about, feelings of distress that are more persistent, not feeling like yourself. If something feels off, you should ask. Because sometimes, with everything going on, as Christy noted, you're so focused on some very basic things. There are other components of your, mental and emotional health that you may have sort of left on the back burner until you felt able to really unpack that. And so, to start early and to go at your own pace. People need different things at different times. So you should ask for help early and often and whenever you need it from, anyone in the system who can provide it to you. And certainly, as a psychiatrist, we feel that, part of our role is to help advocate for our patients and their families, and to sometimes help them, make sense of and navigate complex systems in the medical system, but also the mental health care system. Turning it back over to you, Lena.
Thanks, Dr. Tan. Definitely a lot of resources. Christine, I wanted to bring you in to see if you had anything from your perspective, something maybe you did or something you wish you had done that maybe you could share.
Well, that's absolutely the case. I think there were two parts. One is, the trauma for me was huge, but it was double the trauma for my family. I think I mentioned that while I did not see, what was happening in the ICU, they saw as I'm lying with tubes. And at this point I had, bandages everywhere over my head, and I'm swollen. I wasn't able to communicate, and it was just horrific, but they saw it. And they're still to this day, like we were talking about it's important to share being real about this. I think seeing as my mother watching as I'm lying there, that was overwhelming for her, and we'll not talk about it anymore. So the broad spectrum of the family member is actually quite more important actually than the patient, potentially on that front. The second piece was there is loads of care now that I'm seeing more. I was not ready to deal with my emotions at that point. I was so focused on the physical and then the communication wise. I should have done much more help. But as a volunteer now, I've always encouraged exactly that, is reach out to people as soon as you can. If it's not now, in a month, in a couple of months, going forward, always looking for guidance for both the patient and the family members.
Thanks, Christine, and thank you for the volunteer work you do too. I'm sure it helps a lot of folks out there as well. Okay, moving on to our next question about interacting. So how can someone interact with or support a family member in the ICU? And what are helpful things that someone can bring to a family member who is in the ICU to make them more comfortable? So Dr. Harridge, maybe we can bring you in to hear what you have to say about this and what you've seen done.
Sure. Thanks very much, Alina. And I think when addressing this question, I think what I would want to really offer is that the most important thing you can bring is yourself. The most important thing is to be there, and to be there for a few reasons. Even if your loved one is not awake, as Christine was describing, often the patient will still have an awareness or a sense that a loved one or a supporter, someone who cares about them, is there. I do really see that a lot. The other issue is that when you're present as a caregiver at the bedside, this allows you then to be an advocate. It allows you to be talking with the medical team, asking questions, getting all the information you need, and honestly serving an advocacy role, which is very important. It's also clear that being in the ICU and talking to the medical team is therapeutic for family members or caregivers because it allows a sense of clarity of information and a sense of connectedness to the team and an opportunity to understand exactly what's going on in real time. And that is very helpful in terms of mitigating or improving mental health problems in the longer term. And Dr. Tan may also want to speak to that. The other thing I would just say is that everyone is different. Some families in the unit, when I'm working there, they really, the caregiver, the family member, the spouse, the partner, whoever it is, the loved one, the friend, wants to be there by themselves. And that's a conscious decision because bringing someone else there as a support person sometimes can be burdensome, even though, of course, people have the best intent. And I think it's important to just say that it is different for everybody. Some people feel all they want to do is manage themselves in a really crisis situation like this. Other people feel it's very helpful to have their extended family present. But just to reflect as an individual on what works best for you. How do you manage a crisis yourself best? And to just stick with what works best for you because there is no right way. Unfortunately, just in terms of bringing things in, I said bring yourself. The ICU isn't a place you bring flowers or balloons or typically stuffed animals, this sort of thing. There's a lot going on. There are a lot of infections. It's a dirty environment. Flowers are not allowed because flowers, unfortunately, are dirty. Different organisms grow on the stems of flowers, on cut stems and potted plants. We don't think about that ever, but in an ICU, people are aware of that, and we don't allow flowers or plants. But bring yourself and make sure that you understand how you can help yourself the most in that moment, who can help you, and take breaks. Look after yourself, take breaks, eat meals, and go home and sleep if you can. And that doesn't work for everybody. Some people really need to physically be present and put in a vigil there. But sleep really will help to, foster endurance because it is a long game. And it can be sometimes weeks, months, And sleep, regular eating, and really looking after oneself consciously is really important. And the ICU team will really encourage that. I don't know if Christine or Dr. Tan also wanted to speak to that, Alina.
Thank you, Margaret. I think you've said all the right things that I recall being in the ICU. The importance of resting the family members. My family were exhausted and they're trying to do so many things, not only being in the ICU, but then dealing with my children, making sure they're fed, who's going to do laundry, all those kind of things. It becomes overwhelming. Everything gets double of the work that they need to do. So encouraging everyone to rest as much as they can, but also asking all the questions you need. We've had such an amazing experience at Toronto Western ICU. Someone was there 24/7 for us, but they had asked questions whenever they wanted and whatever they needed, and that was an important piece for them.
Thanks, Christine. And I definitely think the information all of you are sharing is really important. Dr. Tan, did you have anything you'd like to add before we close off?
I think both Christine and Dr. Heritage have lent their expertise from their various lenses. I think just to conclude, I think we're often talking about meeting people where they are, being human, understanding the humanity of the moment, and how profound an event this is for everyone. I think involved patients, their family, caregivers, but also the health care professionals. Sometimes what we do in medical psychiatry and consultation liaison psychiatry is informally also provide support to the healthcare professionals who hold so much as well. And I think, that's a different discourse for a different time, but to understand that, and I think this is a very profound experience all around. So it's been a great privilege to be able to speak to it.
Definitely. Thank you. So I wanted to take a moment on behalf of the patient education and experience team to thank Christine, Dr. Heritage, and Dr. Tan for sharing your insightful knowledge and your experience on this challenging topic. I know it will definitely help a lot of people who are watching. And for those watching, your feedback is really important to us. You can go to the link on your screen to complete the survey at the end of this video. Your feedback helps us to know what you liked, what we can improve on, and what topics you would like to see in upcoming months. And finally, to keep up to date with our health talks or any other current events at UHN, you can subscribe to our patient and family e-newsletter, and you can go to the link on your screen to subscribe. And our next session is in February, and in celebration of Heart Month, we will be talking about general heart health and nutrition. And in the meantime, you can start submitting questions you have for our speakers on the Slido link on your screen. Thank you, and see you next time.